and we're starting with Paul Devanzo, who is Chief Fellow in our T32 Behavioral Science Training Program at the HIV Center, and in our division, actually both our speakers are current fellows. And I've been really fortunate to get to work with Paul in a number of contexts, including the fellowship. He received his master's in mental health counseling at the University of Pennsylvania and his PhD in social and behavioral sciences from Temple University's College of Public Health. He also received advanced training in LGBTQ health education and social service at NYU, where he was also a junior research scientist and project director at the Center for Health, Identity, Behavior, and Prevention Studies. His past work has included developing highly targeted health communication interventions to promote HIV PrEP to transgender women in Philadelphia, as well as opportunities to use behavioral theory to promote more frequent screening for syphilis infection among sexual minority male patients and their providers. He currently has 2 projects investigating attitudes and intentions related to doxycycline for STI prophylaxis among patients and providers. And I think we're going to hear a little bit about that today. His scientific mentor is in the room, Bob Remian. And who's your current mentor? I should know this. Rebecca. And Rebecca in the School of Nursing is his career mentor. And I think I'll wait to introduce your group until you're done. Thank you.
All right. Thank you, Claude. Good morning, everyone. Thank you so much for inviting me to present today. I'm really excited to share not only some updates on these 2 projects that we have ongoing looking at Doxy PEP implementation, but for those who Doxy PEP is still relatively new, just to provide sort of a quick overview of what the strategy is and what the sort of current state of the research evidence is supporting its use. So to that end, here are the things that I want to cover today. Like I said, I want to provide just a brief background on what the current state of bacterial STIs are in the United States. I'll be introducing exactly what Doxy PEP is. I'm going to provide a brief overview of the current research evidence supporting its efficacy to prevent STIs. And then, as I mentioned, I'm going to be introducing these 2 projects looking at Doxy PEP implementation. So to begin, I'll start with a snapshot courtesy of the CDC, showing sort of where we are in terms of the trends and incidence for these common bacterial STIs. As you'll see, things are increasing, particularly for gonorrhea and syphilis. And it's important to point out that this reporting period covers the years 2017 to 2021, which will be important when we discuss why we saw a decrease of chlamydia cases during that reporting period. But also important to note is that these infections are also subject to health disparities where different populations are disproportionately affected. In particular, young people aged 15 to 24, gay and bisexual men, pregnant people. As you also note, there was a startling increase in congenital syphilis during this reporting period, and racial and ethnic minority groups. Now, I mentioned that chlamydia cases, though there was a decrease during this reporting period, this is likely and largely been attributed to disruptions to the sexual healthcare infrastructure that occurred during the early phases of COVID-19. People were not appearing in person for routine screening visits. There were, in fact, clinic closures, things like that, which resulted and particularly affected chlamydia, which in most instances is asymptomatic and typically identified through routine screening. Since that type of screening saw a decrease during this period, that affected our denominators. And so this has been essentially considered sort of as an artifact of surveillance, where in fact the true prevalence is probably right there along and increasing alongside gonorrhea and syphilis. So just to quickly summarize the background here, what we know is that bacterial STIs are increasing, particularly among adolescents, gay and bisexual men, and among racial and ethnic minorities. We know that COVID-19 caused disruptions to our treatment, prevention, and surveillance services, and particularly of these infections, and that this is likely to exacerbate existing disparities that are affecting these populations. We know that in the absence of routine screening, infections frequently go undetected due to being asymptomatic, which can therefore lead to forward transmission. And thus, those that are in increased likelihood of STI acquisition may benefit from prophylaxis or prevention, and thereby preventing infections and thus limiting the potential to transmit them forward. I think it's also important to note, particularly for this HIV center audience, that STI treatment and prevention does play an important role in HIV care and prevention. Not only are HIV and STIs highly co-prevalent, untreated STIs may actually facilitate HIV transmission through different ulcerative and inflammatory disease processes. And we also know in people who are immunocompromised, perhaps due to HIV infection, STI disease course can be accelerated, and the sequelae may be more severe. So now we're going to talk about what exactly Doxy PEP is. Doxycycline itself is not anything particularly new. It's a commonly prescribed broad-spectrum tetracycline-based antibiotic used to treat a variety of infections, everything from acne to pneumonia. Doxy PEP refers specifically to the use of doxycycline as post-exposure prophylaxis, meaning administered by mouth in a 200 milligram dose, ideally within 24 hours and no later than 72 hours after a condomless sexual exposure at any anatomical site. Now I'm going to just briefly cover some of the evidence that we have supporting Doxy PEP's use in preventing bacterial STIs. And I'll focus on one study in particular that's gotten a lot of attention. And that is this open label randomized control trial, which enrolled patients from 501 patients from 2 sexual health clinics. It included an MSM and trans women on PrEP cohort and an MSM and trans women living with HIV cohort. They were randomized 2-to-1 to either receive the 200 milligram dose, again, ideally within 24 hours, but no later than 72 hours after sex, and compared that to a standard of care control. Starting with the PrEP cohort results, as you can see, the top line result here is that there was a 66% reduction in any STI incidence in the Doxy PEP group compared to the standard of care control. In all secondary analyses, Doxy PEP was favored, even in instances where small counts precluded the detection of significant associations between Doxy PEP and STI reduction. And the same is largely true for the HIV care cohort as well, resulting in a 62% reduction in any STI for the Doxy PEP group. In their time to event analyses, they saw a cumulative reduction in any STI incidence of 66%. And in fact, time to first STI was delayed in the Doxy PEP group. So some pretty promising findings. But that's not all the research that's been done on Doxy PEP. Going as far back as 2015 at UCLA, Balan enrolled 30 patients into a small pilot RCT where they were received daily Doxy, so important to note that's different from Doxy PEP, and compared that to a contingency management condition. And in that, they found a 73% reduction of odds of gonorrhea, chlamydia, or syphilis. As part of the IPERGAZE study, men in that cohort were randomly assigned 1-to-1 to either receive the 200 milligram dose of doxycycline, again, 24 hours after sex. And they found a 70% reduction in chlamydia, 73% reduction in syphilis. However, no significant difference in gonorrhea was observed. The Doxy PEP study was the one I just presented on, and I'm noticing now that I think that should be 62% reduction in people with HIV cohort. And more recently, we had 2 abstracts that were presented this past summer at CROI. There was the Doxy VAX study, which in addition to looking at Doxy PEP, also included a vaccination arm with 4C-Men-B, which is being investigated for its activity to prevent gonorrheal infections. In the Doxy PEP arm, again, randomly assigned 2-to-1 to receive the 200 milligrams of doxycycline 72 hours after condomless sex, saw an 85% reduction in syphilis infection, 90% reduction in chlamydia, and 51% reduction in gonorrhea. And also, interestingly, the 4C-Men-B vaccine cuts gonorrheal infections by half as well. And then we have the DPEP study, or the female trial in Kenya. This enrolled 446 non-pregnant cisgender women. They, as well, were randomized 1-to-1 to receive 200 milligrams of doxycycline 24 to 72 hours following vaginal sex. And there were 109 incident STI events reported during that observation period, 50 in the Doxy PEP arm and 59 in the standard of care arm, resulting in a relative risk of 0.88, which was not significant. And therefore, at this time, there's been no observed impact on doxycycline and its ability to prevent STIs in cisgender women and people assigned female at birth, which you'll see reflected in the guidelines further on. Other considerations that are important when considering Doxy PEP, first and foremost, are its side effects, which of course I think are fairly well known, again, given that it's frequently prescribed antibiotic for a number of different indications. These include things like GI issues, pill esophagitis. Doxy PEP's also been known to lead to photosensitivity, so people taking it long-term for things like acne are advised to avoid direct sunlight. Also important to know is that unlike other antibiotics in the class that doxycycline is in, it's not typically associated with any renal toxicity, so it's safe on the kidneys. Other questions I would say that are still outstanding are things like, what are the long-term impacts of using a medication like doxycycline for prevention on the microbiome? Also, how and will this change the presentation of STIs? For instance, will this lead to instances of things like partially treated syphilis, where you have suppressed RPR titers that are important both for diagnosing syphilis and for monitoring its response to treatment? And then I think the biggest concern, the one that's getting the most discussion, is how and if Doxy PEP will contribute to antimicrobial resistance. And on that note, there are a number of organisms that are being monitored closely and assessed for their potential to develop resistance in the context of Doxy PEP use. First and foremost, and the highest risk is gonorrhea. Somewhat less risk, considered intermediate risk for developing resistance, are things like Staphylococcus aureus and Streptococcus pneumoniae. At lower risk are things like Mycoplasma genitalium and the gram-negative bacteria that colonize the gut. And then at the lowest risk, based on the fact that no known resistance has been identified presently, are chlamydia and Treponema pallidum, the bacteria that causes syphilis. So in terms of guidelines, we're starting to get guidelines now when it comes to prescribing Doxy PEP. In early October, the CDC issued their first draft guidelines, and they recommend that Doxy PEP should be considered for gay, bisexual, and other men who have sex with men, and for transgender women with a history of at least one bacterial STI in the past year. However, they go on to say that no recommendation can currently be made, citing the lack of research evidence that I mentioned that supports its use in cisgender women and people assigned female at birth, as well as cisgender heterosexual men, trans men, and other queer and non-binary individuals, again, citing the lack of research evidence that's available right now. We also have guidance from New York State, which has the following recommendations: that Doxy PEP should be offered to cisgender and transgender women who both are and are not using HIV PrEP or receiving HIV care, who engage in condomless sex with partners who are assigned male sex at birth, and who have had a bacterial STI in the past year. They go on to say that clinicians should engage in shared decision-making with cisgender men who engage in condomless sex with multiple partners assigned female sex at birth and have also had a bacterial STI diagnosed within the past year, and to offer Doxy PEP on a sort of case-by-case basis. And from our friends at DOHMH, the NYC Health Department strongly encourages providers to consider prescribing Doxy PEP to cisgender MSM and transgender women who have sex with men and who have had a history of gonorrhea, chlamydia, or syphilis in the prior year. And this should be done based on a shared decision-making framework. So this is all to say where my attention has recently turned. Now that we have guidelines, now that there's research evidence and it continues to mount in support of Doxy PEP, not just continuing to support its use among MSM and trans women, but hopefully expanding that out for other populations as well. How can we ensure that this strategy gets implemented equitably and is seen as acceptable to the populations that stand to benefit from it? And this led myself, with under the mentorship of Dr. Jason Zucker, who's here, to apply for a fellowship from the American STD Association, a research fellowship, to investigate just this question. What are the values, perceptions, attitudes that in part determine both patient and provider intention to prescribe and use doxycycline PEP? And we decided to do this through a series of in-depth semi-structured interviews. And to break down just a little bit further what we were looking to answer. For providers, we were really interested in assessing what their pre-existing knowledge of doxycycline PEP was and how this varied in terms of practice setting, clinical training, et cetera. In terms of values, we wanted to know what those values were and how their perceptions and concerns may affect their intention to prescribe doxycycline. And did I do that?
No.
Okay. Oh my goodness. All right. I don't know if the people on Zoom can hear that, but we're getting a test of the fire system. So, all right. I'm hoping that it'll.
Paul, this is
Okay.
a test of you.
Yeah. No. All right. Okay. I think where I left off, we were also interested in assessing we wanted to look at these factors as part of a knowledge, attitudes, and practice implications model, which has been frequently used to sort of evaluate the implementation of the research findings into clinical practice. So an appropriate model to use in this instance. For providers, we wanted to similarly assess their general knowledge of STI prevention, and Doxy PEP is an option among all the available options to prevent STI. We also, of course, wanted to assess what their perceived barriers and benefits were to the use of Doxy PEP. And we wanted to also look at how their own perceived vulnerability to STIs affected their motivation to engage in different aspects of clinical care. Excuse me. And this we wanted to evaluate as part of an information motivation behavioral skills model, which among other things has been widely used to assess acceptability and use of HIV PrEP. So again, we consider it to be an appropriate model to use in this instance as well. Our methods were fairly straightforward, given that this was a small qualitative. All right. Our methods were very straightforward. We recruited from local sexual health clinics, university health centers, PrEP clinics, and primary care settings. All interviews are being conducted on Zoom, which I'm wishing I was home right now on Zoom doing this. The interviews were structured very much like key informant interviews in the sense that what we were really interested in were both patients and providers' firsthand experiences with Doxy PEP. And I mentioned the KAP and IMB models. Those mostly help inform the content and structure of our interview guides, but we're really going to use and are using an inductive approach to analyzing these transcripts, being that this, as an early qualitative pilot, is really more about hypothesis generating. I don't spend too much time on this slide other than just to show you where we sort of perceive these different factors falling within the models that we use. Again, the important things and what I'll be focusing mostly on today, just due to time and the fact that we're further along and are actually nearing saturation with our providers. I'll be focusing mostly on the provider side of the project and some of our preliminary evidence, but we're really looking to assess the accuracy of their information around STI prevalence, the knowledge of other STI prevention modalities. It's a very effective alarm, I have to say. And in terms of attitudes, whether or not what their concerns were about antibiotic resistance, the quality and clarity of the guidelines that they received, competing priorities, and then practice implications obviously involve things like clinic workflow and disruptions to sort of day-to-day operations at their clinical site. So I mentioned we're going to be focusing mostly on the providers. We've done 16 interviews so far, with a few more scheduled. We have 6 completed from internal medicine physicians with an ID who are ID specialists. one emergency medicine physician, one pediatric physician with an ID focus, two pediatric physicians with an adolescent medicine subspecialty, two PAs, and four NPs. And the average number of years post-training has been 12 with a range of 2 to 30. So a fairly diverse group in terms of training and experience. So we were very pleased with that. I'll just go through some of the very kind of like basic top line findings from these qualitative interviews that we've conducted so far. As it pertains to knowledge, the majority of providers that we've interviewed are actually already prescribing Doxy PEP. They're, as you would assume, very well versed in STI prevention methods, not including but not limited to Doxy PEP, and they have been able to identify barriers that their patients experience in trying to access sexual health care. In terms of attitudes, they've been generally positive. There do remain, again, not surprisingly, significant concerns about antimicrobial resistance and how Doxy PEP plays a role in that. They do, however, trust the research evidence that's been presented to date, supporting the efficacy of Doxy PEP. Although they are noting, and this is of particular interest to me as someone approaching this from sort of a social behavioral vantage, that they're noting disparities even among their own patient populations in uptake and perceived acceptability of Doxy PEP. In terms of practice implications, there have been no real significant descriptions of workflow impediments. It seems to be something that's, for those providers who are already offering it, something they've been able to integrate fairly easily. And in fact, some have taken the initiative already to set up customized EMR-based prompts in, like, let's say Epic, to alert themselves and their colleagues to start recommending Doxy PEP to patients who meet certain criteria. One unanticipated challenge that has come up in a few of these interviews are the role that pharmacies and pharmacists have played in potentially, they've used the term gatekeeping or preventing prescriptions being filled for Doxy PEP. So to add a little bit more context to some of these findings, I've sort of pulled just a few exemplar quotes from some of these transcripts and interviews. So starting with knowledge, when I've asked providers, tell me what you know about the use of doxycycline for STI prevention, we've found a number of providers, as I mentioned, who are very early adopters, who are really right out of the gate ready to prescribe it to their patients, exemplified in the following quote. So I started prescribing it actually for a few select patients even before the study came out in April. There was the IPERGAY study and a couple of other studies that I think suggested it was going to work. Contrast that, well, not contrast, but in relation to other providers who are perhaps enthusiastic about Doxy PEP, but are still awaiting more research evidence before they fully endorse it and begin prescribing it to their patients, like the following provider. I read the recent study, and the study is actually pretty good. I think Doxy PEP was somewhere around 70% effective, something like that. I want to know, what about the rest of those people? Like, why didn't it work for the rest of the people, And so I think it warrants another study for sure. In terms of attitudes, when I've asked providers, what do you think are the most important features of a non-HIV STI prevention modality? One recurring theme has been its ability to empower patients, as the following two quotes exemplify. My approach as a provider has always been kind of like an all hands on deck approach. I almost call it like a menu, like presenting options for patients and really just working with them to see what works for them in their lives. Everything from condom use to PrEP to Doxy PEP and a whole range of issues. And I think that really makes people feel empowered and that there's a lot of things they can do to prevent disease. Similarly, my patients are all just really excited about it being Doxy PEP. They're like, oh, I can't believe this is here. I'm so glad. Now I'm going to feel so much better about it. We have a lot of patients that have really bad health anxiety, which obviously stems from the HIV epidemic and just the stigma regarding STIs. So as far as their mental health goes, I feel like this is making them feel a lot better and more in control of their health. Also related to attitudes, I've asked providers, what are some of the challenges in doing non-HIV STI prevention? And a frequent and recurring theme has been their patients' access or inconsistent access to both health care and health information, as exemplified in the following two quotes. Patients started asking about it right after CROI. People that started asking about it first were generally white gay men who are already on PrEP. They're very PrEP savvy and they are sort of health proactive with their visits. So people are already doing it. The people who are savvy and read the papers and watch the blogs and stuff, which I think provides good context for the next quote. One of my patients said something really interesting that I thought I would share. He sees when people are on the apps being like, I'm on Descovy and I have Doxy PEP, that he kind of sees it as like a privileged white person thing, for lack of a better word. And so he was like, I don't want to be on Doxy PEP. All those guys are like so annoying. All right, in terms of practice implications, as I mentioned, not many disruptions have come up in these interviews, things that affect workflow, et cetera, other than this role that pharmacists are playing, as exemplified in the following two quotes. And I'll just say, if there are any pharmacists in the audience, I appreciate and respect the work that you do. I am just the messenger. When you're trying to do a prior authorization and you're talking to some bleep pharmacist who's like, no, you can't have this. Prove to me that this patient has an FDB, FDB being a database for approved drug usages. They know what you're writing it. They know what you're writing it for, and they're like, I don't feel like it. I really resent refusals like that at the pharmacy level. It's like, that's not your decision. That's my decision. Relatedly, perhaps less personal and more functional. One hiccup we are seeing in terms of workflow is figuring out, there's like one kind of doxycycline where when I send it in, a couple of the pharmacies will reject it saying, like there are two forms of doxycycline, hyclate versus monohydrate. And you can tell it's like a pharmacy thing being unwilling to switch it. And at the conclusion of every interview, I've just asked providers to sort of assess their own intention to prescribe Doxy if they're not already prescribing it, or their enthusiasm about the strategy overall. And on that 1 to 10 scale, the average response has been a 7 with a range of 2 to 10. So again, generally positive attitude towards it, but still a lot of variability in even the limited amount of providers that we've talked to so far. So where do we go from here? Well, the goal is to take what we're learning from these interviews and use it to develop two surveys, one directed towards patients and one directed towards providers, to really better understand how these factors that we're assessing, attitudes, values, knowledge, et cetera, are associated with intention. And at this point, we're more looking at intention to continue using Doxy PEP for patients, because many have already obtain prescriptions, and for providers continuing to provide Doxy PEP to their patients. And the goal, of course, is to use what we learned from that quantitative analysis to identify appropriate targets for health communication and health education interventions to hopefully increase the perceived acceptability of the strategy from both the patient and provider perspective. And to that end, and I won't have too much time to go into this, but we were recently awarded a pilot through the HIV Center to do just that, which is to develop these surveys, quantitatively assess how these factors are associated with intention to both use and prescribe Doxy PEP. So very briefly, just to summarize what we've discussed so far, we know that Doxy PEP is effective for preventing bacterial STIs in cisgender men who have sex with men and trans women who have sex with men. From our own interviews, we've determined that many providers are already offering it to patients, particularly here in New York City. Provider knowledge and enthusiasm and intention to use Doxy PEP is relatively high, though barriers still exist that will likely require additional education and training to overcome. Antibiotic resistance definitely remains one of the biggest concerns, primarily among providers, but among some patients as well. And patients with existing access to health care and health information are already seeking Doxy PEP and talking about it and bringing it up in their healthcare encounters. However, we need, I would say, to address these factors of patient knowledge, attitudes, and values in ensuring that as we increase the scale up and rollout of Doxy PEP, that we're doing it equitably and expanding the Doxy PEP using population beyond that, perhaps more privileged, has more access to healthcare, et cetera, population that was described in some of those quotes. So a lot of work still has to be done. And I know I've run a little bit over time, but let me just thank a few people. Of course, the doc.
You started very late.
Oh, okay. Well, either way, we've reached the acknowledgement. So I do want to thank Dr. Jason Zucker, Carrie Carnevale, and Joan Bosco, who sort of make up our informal Doxy PEP team, my scientific mentor here at the HIV Center, Bob Remian. And also special thanks to my fellow fellows who've been very helpful and supportive in helping me prepare this presentation today. And of course, a very extra special thanks to all the patients and providers who have so generously contributed their time and expertise to this work. And with that, I thank you for your kind attention. And I don't know if we didn't really quite discuss how we're doing questions now. Okay, I'm happy to take questions. And of course, you can email me at any time if things come up later.